Good afternoon, everyone, and welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Please leave your questions till the end. Please enter them in the chat, and please answer a brief survey that will be sent to you immediately after the presentation. It will let us know that you are present here today. And finally, our speaker is courtesy of the Division of Immunology, and it will be myself. It's a pleasure to introduce Dr. Hannah Laure Elfassy, who is an adult immunologist and allergist at Sacré Coeur Hospital in Montreal, where she has headed the department since its creation in 2019. She also works as a clinician and teacher at the Children's Hospital here at McGill. She completed her medical training at University of Montreal and did one-year fellowship in primary and secondary immunodeficiency in adult and children's within the McGill network. Dr. Elfassy has a particular interest in cases of dysimmunity and is a co-founder of a clinic specializing in autoinflammatory diseases. Welcome, Dr. Elfassy. Thanks for being here.
Thank you for having me. So I hope I'll keep on time track, and there's a lot of stuff to cover, so I'll do my best, and we'll skip some part, and it will be a pleasure to come back if we have the occasion. So today's objective is mainly to define the clinical manifestation of the most common autoinflammatory diseases using genetic testing and approach the different targeted treatment that we have available. So I have a few conflicts of interest. I am a presenter for a different company, and I'm on different advisory boards, committees, but I don't think it's anything related to today's presentation. So I like to talk about a little of history about autoinflammatory diseases. So it is an entity that has been described like before even Jesus Christ era in the ancient Egypt. But it's been only a few years now that we definitely has a clear definition of what is exactly these syndromes. At the beginning of the medicine around the year 50s, we defined those patients as cyclic fever or Mediterranean fever. And then with the era of genetics, we do discover that not all of those patients with cyclic recurrent crisis are related to the actual FMF and related to the MEFV genes mutation. And it's been now 25 years that the genes era is here, and we discover more and more that a lot of our FMF or supposedly FMF patients are not really related to these mutations. And nowadays, before I started my training a few years ago, this table was like very, very short inside of the residence room. Now it doesn't fit anymore, and it's not even exhaustive. So we're gonna not discuss all of those syndromes today, but mainly approach the 5 historic one. Historic by the fact that they were the first 5 ones discovered, and also the one that we usually refer as a clinical cases. And I like to base my presentation on cases. So I'm gonna have your help with answering with me those questions. So let's start with an 18-year-old girl. She has a diagnosis with FMF, which is a heterozygous state of M694V mutation. And she reports having episodic fever symptoms associated with abdominal pain despite treatment of colchicine of 1.2 milligram per day now the last 6 months. From the following choices, what do you think could be the cause of this clinical situation? Maybe she has a colchicine-resistant FMF, and she required to add another treatment, which is anti-IL-1. Or she's non-compliant to her medication. She has a hormonal change linked to her menstruation. That's why she do have this abdominal pain. And mainly, or because of a drug interaction with natural product that she has been taking since 6 months. So who thinks it's number 1, just by raising hand? Who thinks it's number 2, 3, and 4? Okay. So I'm going to answer at the end. So FMF is depending on where do you live and the population that you're facing, the prevalence will be very broad. So in the Mediterranean area, it's 1/500 to 1/1,000 patients. It is the most common adult autoinflammatory disease, and mainly on Sephardic Jews, Armenian, Turkish population, southern Italy, also north of Greece and Arabs. And in fact, there's a foundation effect because the hypothesis is that tuberculosis and the leprosy back then was very high, and that this mutation will protect against having a lethal inflammatory secondary effects to those infections. And that's the hypothesis of this foundation effect of this mutation in this population. So MUFV gene is a 10 exon genes. The most common mutation is the one our patient has, the M694V, and it is also the most severe phenotype. And 30% of our FMF will only have a heterozygous state, so it's not mandatory to have 2 mutation alleles, but at least one to have the label of FMF. With time, we know that some mutations that has been clearly described in the past as probably not pathogenic mutation, but most likely polymorphism, especially in this population. And for example, the mutation 148Q is not considered anymore to be pathogenic, but just a VUS or a likely benign change. So the MUFV genes codes for a protein named pyrin. Pyrin in Greek means fever. And pyrin is an immunoregulatory protein that involves more than 700 amino acids. And it is expressed in most of the innate immune cells that are present essentially in the serous and the synovial fibroblasts. So that's also related to our patient clinical presentation with arthritis and serositis. The fact that the pyrin is mutated, not normal, it will be deactivated and so not phosphorylated. And this will imply and have a problem with the interaction with the caspase-1 that create the inflammasome. And so this activation state the threshold of activation state of the inflammasome will be a lot lower than usual, and our patient will produce IL-1, IL-1 beta, and will have the symptoms that we're going to discuss without clear signals of alarms that we usually have with bacterial dams or PAMs that trigger that cascade. We do know also that there is not just a genetical involvement, but also an environmental factors. So in my patients, if they usually born outside of the Mediterranean area or they spend most of their life outside of it, they usually have a tendency to have a less severe phenotype. So the treatment will also be related to the environment of the patient story and where they live also. So it's the part of the questionnaire that we have to assess during our clinical evaluation. So manifestation, most of the patient, 2/3 will have symptoms before the infancy, but still 30% of them will have symptoms only in the adulthood. So it's not because it's an autoinflammation that it has to be excluded of the adult world. And I have patient that has been diagnosed at the age of 65. So it exists in the adult. It is although low penetrance mutation usually and less severe phenotype, but it's something we should still think about. Usually the attack is a few times per year, between 2 and 6 times, but it can vary. The severity of the attacks can vary also. And what I would like to highlight is that it is not a regular interval timing. So I usually listen to, some comments that, it's not every 4 weeks, it's not every 6 weeks, it's whatever, doesn't really relate it to a special timeline. But it is not the case. It's not a special timeline. It is irregular interval, but those crises are very stereotypes. They do resembles one to the other, and the patient can also predict they're going to come. And there's some triggers that are clearly identified, and one of them is the temperature, the physical activity activity, a surgery, menstruation could be also a trigger for women's. And one of the worst is the physical or emotional stress. And so those patients are usually stigmatized, like you have abdominal pain because you're stressed. Most likely it's a functional issue, and a lot of misdiagnosis is passing in that area, unfortunately. And a contrario to the autoimmune world, where stress does not really correlate clearly with the patient's symptoms, in our world, in autoinflammation, it do correlate with the patient crisis. So clinically, most of them have fever, but again, it's not mandatory, especially in the adult world or in heterozygous states. They will have sinusitis that will involve the lungs, the GI, and the genital area sometimes. And usually the pain is so difficult that most of them has a history of cholecystectomy or appendicectomy. It's a pseudo-surgical state. And during that state, they are in ileus, so they're constipated. And then once the crisis resolved, they usually have diarrhea. They can also have lymphoproliferation with lymph nodes, splenomegaly, and they usually also have a mono or oligoarthritis, especially in the lower limb with predominance of ankles and knees. Some of my patients will have also mild ulcers, and very rarely it is debated in the literature that meningitis, aseptic meningitis can present in FMF patient. But what is very important is that between the two attacks, my patient is completely symptoms-free. They are perfectly functional. They don't have any problem. It is not a chronic issue at a usual state. The picture here is very pathognomonic of the FMF. It is what we call a pseudo-erysipelas, so a redness inflammatory issue usually that is below the knee. And if you do an echo on that, you will see inflammation of the tissues, and you will see sometimes onthesitis, but not an arthritis. Also, a message that I would like you to remember, it's always to objective the fever and document it, because everyone is allowed to have a GI pain with fever that is not inflammatory. Everyone is allowed to have endometriosis, even our own FMF patient. And sometimes the easiest thing is to come back to the baseline. So you do assess the patient during an episode, if possible, of course, but ideally to have a physical exam and physical assessment during a crisis that they judge to be the typical one. And you can easily dose a CRP or a CBC during the episode just to document that this episode is really inflammatory or not. Amyloid A serum is also another inflammatory markers that we do use in clinics, but it's itself could be just a presentation, but that's also a marker that we do want to assess in our FMF patient, and we do follow in time. There's a lot of criteria for FMF. The one that I like is this one from Eurofever, but the one that's usually used is the Livney criteria. But it basically mixes of the genotype and the phenotype. So both are usually mandatory as a heterozygous or homozygous states. So the pyrine is a 10 exon MFA gene, is a 10 exon genes, and most of the mutation will happen in the exon 2 and the exon 10 for the pathological one. And this is a website that I regularly visit to see what are the clinical significance of my mutation, especially if it's a mutation that is not well documented to be pathogenic. And the InFever database that exists in 2002 are very reliable regarding the clinical prediction value of this unknown mutation that sometimes we do have from our genetic panel that we do for our patient. What we really emphasize is sometimes our FMF patients, they do have clinical issue, but we don't want them to have complication from that disease. Of course, complication will be the amyloidosis. I'm going to talk about it after, but sometimes you can have chronic adhesions that will lead to fertility issue, for example. You can have also very destructive hip involvement. My patient could have, hip replacement at 20 years old because of that. They can also develop mesothelioma or cirrhosis, and very rarely some cases describe of prolonged fever. In my situation, I've never had any patient with it, but high dose of cortisone and anti-L1 can be a choice of treatment for the patient that present a very prolonged FMF crisis. Amyloidosis. So for those that are good in geography, this is Congo, South Africa. And the red Congo is the coloration you should ask when you want a patient to be assessed for amyloidosis. So to remember that, if you do feel this is something you're looking for, 99.9% patients with amyloidosis will present with a kidney involvement before having any other organs involvement. So yes, you can have spleen, GI, liver, testicle, thyroid, heart involvement of amyloidosis, but most of the time the kidney will be there first. So regularly assess the urine function and the creatinine function of your patient will prevent you from, passing not knowing about any amyloidosis ongoing. And if you have any doubt, you can easily perform a salivary glands biopsy to assess if there is any red Congo coloration. And it's a pretty reliable test with 60-70% sensitivity. So if you have a doubt on the kidney involvement and you're not sure you want to do a kidney biopsy because the residual kidney function is low, you're afraid of a complication, you can assess a salivary glands biopsy first. Treatments, of course, we do treat symptoms. So our patient will have NSAIDs, antipyretic treatment, and most of the time opioid treatment because it is very, very painful. But most of them will have a prophylactic treatment, and we do love the colchicine. So colchicine has different hypotheses of actions, but it is an anti-mitotic and anti-cytokine effect. So it inhibits the microtubules to duplicate, and so the cells cannot duplicate itself and cannot express more genes of inflammation. That's the hypothesis behind the mechanism of action. But of course, colchicine has been studied before us for gout, and the mechanism of gout is not related to the microtubules or the pyrine inflammasome, but more of NLRP3 inflammasome. So it has other mechanism of action, most likely, that we do not understand quite well up to today, unfortunately. So the experts suggest that to decrease the risk of amyloidosis and to improve, of course, patient quality of life, we do have to control the patient, but we do also have to control the subclinical inflammation. So if your patient do have high inflammatory markers, so CRP or AAS in between crisis, that's a reason to updose the treatment, even though clinically he's perfectly fine. We usually set goals when we treat patients, and back then we were like zero crisis. That's the goal. The new generation, everything should be perfect. But nowadays we're a bit more lax, and we aim for less than 3 crises per day. And especially if the crisis has clear triggered, we're more reassured about the inflammation state of the patient. And it should have less functional effects. So less than 5 days per year that they should miss work or school. And of course, if you have to monitor for amyloidosis complications. So if a patient has amyloidosis complication and do not have any symptoms, it's also a reason to updose the treatment. For our patient, it is very rare that our FMF patient will be colchicine resistant. And tolerant is different than resistant. And if a patient is resistant, typically he will have 1 or more attacks per year, and you will have inflammatory markers usually between the attack too. 27% of our non-responder to colchicine are non-compliant. So that's very, very common, and we should assess it regularly in the clinic. And it is an adult issue most of the time. So in the less than 10 years old patient, it's less of a problem. Then the adolescence is more of an issue. But in the adult, here they documented to be 5-6%. I will say it's way higher for me. Don't know if there's any rheumatology, but colchicine is like the Plaquenil. They take it, but officially, but when you ask, they forget it a lot. So precaution with colchicine, it is eliminated by the bile and the enteral routes with the cytochrome P450-3A4. So there is a lot of interaction with any other medication, natural health products. So that's really something you should also reassess regularly in our clinic. And the dose is one of the medications that the dose per kg is not clear, but we aim for max at 3 grams per day in our patient. And it doesn't really matter if it's once, twice, or 3 times per day in the adult. And there is an increase of peristaltism with the colchicine. So the patient will have diarrhea, and it is a transitory state. So just to emphasize that with the patient, there's a lot of different techniques. So to make the GI issue less of a problem. So a slow increase of the dose, lactose-free diet, split the dose, and sometimes we do use Imodium. For the rare adverse event with the colchicine that involve liver or myelosuppressions, it is most likely in our patient with kidney failure. So it is a very difficult in those patients to monitor the colchicine, but most of the time it doesn't really have any issue. It is very safe in pregnancy and in breastfeeding. And so we do not stop the colchicine during those periods. It is safe in pregnancy. If the patient has been labeled as a resistant or very intolerant, you can add the treatment of anti-IL-1. And I use it cautiously that I add and not replace the colchicine, because now it has not been studied to prevent any amyloidosis. So the only treatment that do prevent is the colchicine. So we still aim to keep it and to add the anakinra to control better the clinic or the subclinic issue. It is a safe medication in immunology area. It's very, it's very safe. I don't have a lot of infection related to this medication. It is a very short action medication. So if there's any infection, you can easily stop it. And within a few days, your patient is back to his normal immune state. And there is local reaction on the site of injection. And also something that we may forgot to say, it's the weight gain secondary to it, because the patient metabolic state is so high, and not because of the uncontrolled issue. Once it is controlled, the inflammation, they have a tendency to stock more and weight gain. So that's something to mention to your patient when you start the treatment. If the anakinra is really working, then usually we can switch to canakinumab, which is basically an anti-IL-1 blockage, the same mechanism of action of the anakinra. It is indeed the only one FDA approved. And the study is the one from De Benedetti, so published in 2018, the cluster study. So they took patients on colchicine, they add the canakinumab, and this basically resolved a lot of the baseline number of crises. The baseline inflammation has a great outcome clinically, but also bioclinically. So if you have a patient that is IL-1 driven, and canakinumab can be more easily optioned because it's a monthly injection and not a daily injection, contrary to the anakinra. The rate of infection is a bit higher with canakinumab, but still not something that is that is a lot of a burden for our patient. So if we answer the questions that we asked at the beginning, most of the time, the patient will be non-compliant. It's very, very common. That's why they are resistant. It is very rare that a colchicine-resistant patient will be heterozygous. So in her case, I don't think it is the case. And hormonal changes, yes, can induce FMF crisis, but it is still more frequent to be non-compliant. And a drug interaction with natural product usually will increase the colchicine effect and the toxicity is effect of the colchicine, but usually do not reduce it. So that's why it's not the last answer. So next case, it's a 26-year-old Moroccan woman with no family history of consanguinity, but with a maternal grandniece diagnosis with FMF. She's referred to you by internal medicine for recurrent mouth ulcers since the age of 10. In the questionnaire, she reports occasionally diarrhea and some doubt about oral pathology. You also note that she used 5 courses of antibiotic during the last year for upper respiratory tract infection. Which of these following tests will not be part of your management plan? So first, fecal calprotectin for screening of IBD. Secondary, ENT referral for surgical removal of the tonsils. Genetic sequencing of FMF genes, even though she has no fever. And testing for HLA-B51 for Behçet disease. So who say one that will not be part? 1, 2, 3, and 4? Okay, so we'll have the answer after. So we are discussing here PFAPA. PFAPA aims for periodic fever with aphthosis, stomatitis, pharyngitis, and adenitis. Basically, the symptom is in the name. I don't think they really bother to do an acronym, but it is a pediatric, by definition, it is a pediatric disease. Usually the onset is before the age of 5, and by 10 years old, they will usually resolve, and they will have constitutional symptoms and all what is mentioned in the name. So ulcers, cervical adenitis, pharyngitis, and it is an exclusion diagnosis. So you should exclude cyclic neutropenia, of course, primary immunodeficiencies if it's not mentioned. And usually the patient do not have implication with the growth or the any developmental issues. And contrario to the FMF or the other autoinflammation disease, it is something that is very, very periodic and very cyclic. That's the only one that is really sharp in the timing. Unlike the monogenic disease, PFAPA is really a complex polygenic disease, and we also know that there is environmental factors. In fact, we collect a database from a Turkish population that do report they do have mouth ulcers, and they noted that this population will have a SNP that has some polymorphism near some genes that code for IL-12, STAT4, IL-10. Those cytokines are all involved in the inflammation pathway, especially the interferon gamma pathways. And IL-10 is an anti-inflammatory cytokine, and it's usually decreased in those SNP polymorphism. So that's the correlation that we made for the aphthosis patients. And in fact, clinically, those patients, when they are on flare, they do produce also more of IL-12. So it's not just a genetic polymorphism. Clinically, the functional tests do show that those patients are prone to excessive Th1 activation. We also regroup a cohort from a Turkish database for HLA typing, and we did notice that there are some HLA that are also related to PFAPA. Clinically, honestly, we don't assess them regularly, but it is something that we can aim to develop if we want to. Then this database from the Turkish database has been melted to the Biobank of UK, the one with the genetic testing, the new trend 23andMe and the swab test. Where are you from? So they do cross those database, and they do notice the same thing. Those genes are also having those patients with a Behçet or with recurrent aphthosis of PFAPA. They do have those SNP allele more frequently described. So for me, the Behçet patient and the recurrent aphthosis and PFAPA is more like a spectrum, and involving the innate immune system and causing an abnormal adaptive responses of the T cells and the symptoms that develop. PFAPA, pathophysiologically hypothesis besides the inflammation that we discussed, like why is it really cyclic? Why to remove the tonsils will heal 95% of our patient? It is pretty interesting, but for now we don't have really a clear answer why the tonsils are centered in this disease. It is something to look for in the research eventually, but in the pathology, there's T cell activation that we do see in those tonsils that have been removed, but it is not clear like how it managed to control the disease. So PFAPA, a bit of a reminder, just for the adult. Usually we do not label adult or passing 18 to be a PFAPA patient. Usually we do say PFAPA-like or an autoinflammatory disease of that is unclassified. But some of our adult patients do present with recurrent fever and features of ENT features that those patients have, but they also have an extra ENT involvement most of the time with GI issues and headaches most of the time. I like this slide. It resumes well, and that's how I try to differentiate. But again, for me, it's more as a spectrum. And for the Behçet patient, they do have a pathology that is more common than the PFAPA. They do also have skin involvement with erythema nodosum, some pustules or pseudofolliculitis, usually in the upper arm. They can have uveitis, GI issue, and of course, the neuro-Behçet involvement. And contrario, the PFAPA patient will not have a systemic issue. It's really ENT centered. Treatment for PFAPA is also, symptoms related, so Tylenol, NSAIDs, and tonsils removals. But we usually let the patient with a prednisone attack plan that could be 1 to 2 milligrams per kg, usually max 60, that they can use as soon as the symptoms start and to repeat 12 to 48 hours after. But it has an increasing risk of frequency of the attack afterwards. And sometimes we do have to co-treat those patients with a prevention colchicine treatment. And Anakinra, if needed, is also something that we can also assess. And those patients do not have risk of amyloidosis, so it's really to improve their quality of life. For complex apoptosis, colchicine do work very well, but sometimes it is not enough. So of course you can use a corticosteroids anesthetic cream for the sores inside the mouth. You can also use apremilast or ustekinumab. And personally, the apremilast is magical for those patients. It is very efficient treatment. So if we do go back to our pre-test question for the case number 2, in fact, yes, you can ask for a fecal cap protectin. It is an extra GI manifestation and should be part of the workup. The genetic sequencing of MEFV could be done if the family history is positive, and our FMF patient, 10% of the case do have mouth ulcers. And HLA typing for B51 it could also be assessed if you have a doubt on the Behçet disease. But a referral for ENT is maybe too soon, especially in this case, there's recurrent infection. So we should probably wait and make sure it is an exclusion diagnosis in this patient. So case number 3, it's a 54-year-old Italian patient diagnosed 2 years ago with an undetermined unclassified autoinflammatory disease. Since the age of 2 years old, he has experienced fever with abdominal pain, arthritis in the lower limb, headaches, and a macular rash, and approximately 8 times per year since the age of 2. Was the first time I saw him, right after 50 years of history. He also has an IBS labeled and no significant family history. At the diagnosis, his inflammation parameters were like impressive. CRP of more than 200, AAS over the upper limit that it can be dosed. And yet, surprisingly, he had no evidence of amyloidosis that was documented. I ran a genetic panel that was eventually went back. And so which genetic mutation you think most likely I will find in this patient? Number 1, MKD gene mutation, because it is rarely associated with secondary amyloidosis. Number 2, homozygous mutation of FMF, M694V mutation, because it is very prevalent in the Italian population. I will not find any pathogenic mutation because there's no family history of cyclic fever, or the last option, which is a mutation in TNFRS F1A gene, given the frequency of the attack that is very long and very frequent. So who say number 1? Who say number 2? Number 3? Number 4? Probably the right answer is like, I'm going to have a ton of VUS that I will not know what to do with it, but so we'll go back to the answer. So I would like to discuss with you the third historical autoinflammatory disease, which is MKD. MKD aimed for mevalonate kinase deficiency. And back then we used to call that hyper IgG syndrome. And that's a name we used to drop more and more because our patients sometimes do have high IgG, also has high IgA, but pathophysiologically, it's not, for now, it's not clear why there is this association. It's maybe just an association and not the cause of it. And 20% still of MKD patient has normal IgG level. So that's a name that we more and more abandon for the MKD monography. So it is a rare disease. 1 or to 6 patients over 100,000 patients, but depends again. If you have a Netherlands patient, the prevalence is very, very high. So your suspicion should be higher also. It is a recessive disease. So most of our patients are compound heterozygous for this disease. And they are usually from North Europe, so Netherlands, as I mentioned, but also French or Dutch patients. The onset of these symptoms usually before the age of 1 or 2 years old, and the duration of the attack is pretty long, so 1 week usually, and it can happen every 2 to 8 weeks. So MKD is an enzyme. And depending on the severity of the mutation and the activity, the residual activity of the enzyme, you will have a phenotype that will be different. So a complete mutation will lead to a complete deficiency, which is usually a life-threatening mutation. But most of our patients will have a mild or a moderate residual activity, and they will present with autoinflammatory symptoms involving the fever, of course, rashes, mild arthralgia, and usually also lymphadenopathy. And I also mentioned the IgD levels. And we do like in immunology to have functional testing. Of course, genetic is great, and I love genetic, but sometimes to have a functional test is faster and easier to interpret. So you can definitely dose the urine levels of acid mevalonic, and especially during a crisis. And this will give you right away the answer. You can ask for genetic after, but at least if you're in a rush, there's something very easily assessed as a urine analysis. And neurological involvement in MKD was not something that we really had as an intention, but we recently had some case reports that we published of 2 presentations on the adult with fever and an early onset of stroke. So the inflammation in this patient was so bad during the last 50 years that was not controlled that he presented with a severe stroke. Now he's perfectly fine and has completely recovered, but still was something very worried. Bon. A bit of the pathophysiology of this enzyme that is involved in the cycle de Krebs, so the cholesterol pathways, and it's not clear why a decrease of this activity will lead to decreased production of the isoprenoid, but we're not sure how this decrease will link to an IL-1 inflammatory state. It is still an ongoing research base, but it is definitely involving the IL-1 because IL-1 is the treatment number 1 for this patient, and it's working very well. So we usually go with the canakinumab, the long-action anti-IL-1 treatment that can be given every sometimes 2 weeks to up to 8 weeks, depending on the patient's symptoms. And if it is not enough, then you can switch or add an anti-IL-6 and corticosteroids. Bone marrow transplant is left for the severe complete enzyme inactivity most of the time. And in some, let's say in some population or in some countries, unfortunately, these anti-cytokines are not available. So the anti-TNF, especially the etanercept, is used in those populations, but that's not the first choice at all. So the answer here is a recessive mutation of MKD, as it is rarely associated with secondary amyloidosis. And in fact, it's only 4% of those patients that will have amyloidosis. And the homozygous M694V mutation is very prevalent, but it is, if it's not treated for 50 years like that, I will say the chance to have amyloidosis is pretty high. It's not because you have no family history of cyclic fever that you cannot have this mutation, this entity, because it is recessive. So most of the time, the parents are carrier and they pass it through the family. And a mutation of TNF-F1, given the frequency of the attack, TNF-F1A gene is also ultra rare. So most likely we are facing an MKD cases here. Case number 4, so it's a 12-year-old Caucasian male referred for cold urticaria with a painful rash, headache, and fever. On physical exam, on examination, you note hypergammaglobulinemia, that is polyclonal, a CRP of 200, and neutrophilic lymphocytosis. His father and grandmother suffer from early deafness, and you perform a skin biopsy that showed neutrophilic infiltration. Which of these tests will not be part of your initial workup? So hearing tests, genetic sequencing of NLRP3, bone scan, or MRI of the brain. So I'll pass and I'll come back for the answer. So I would like to approach with you for CAPS. CAPS aim for cryopyrin-associated autoinflammatory syndrome, and it is a dominant mutation involving gain of function of the gene NLRP3. That gene's code for a protein called cryopyrin that is expressed in the innate cells, including neutrophils, and it will present as a spectrum, again, depending on the residual activity of this enzyme. And you can have a mild presentation, which is FCAS, so familial cold autoinflammatory syndrome. You can have a moderate state, which is a Muckles-Wells syndrome, and a very severe case, which is SINCA-NOMID, that is essentially a neonatal presentation. But we can also have an adult presentation because of mosaicism that we discovered recently as a possibility. Those crises, they have the particularity to be induced by the cold, and usually they do not happen like right away, but they will happen a few hours, up to 12 hours after the cold exposure. So that's something to question again. And those patients will have a rate of amyloidosis that is pretty high than the high MKD, for example, or the FMF, up to 25% of amyloidosis, especially the severe phenotypes. There is neurological involvement. If not treated, unfortunately, we do have this same patient has a severe intellectual deficiency because he was not treated properly or accurately, or was not diagnosed because of the rarity of the presentation. And they can have deafness, and they can be also blind. So that's a very, very very important to really assess those patients as soon as you can. And neurological hearing loss correlate very well with the MRI inflammation of the cochlea. But all of our patients, they will have audiogram at the diagnosis and as a follow-up. Criteria diagnosis is, of course, mandatory high inflammatory markers with at least 2 of the 6 classical presentation, and with genes mutation. So basically the answer to this case is probably that I will not do a bone scan. So the bone scan for remodeling is aimed for a Schnitzler syndrome. Usually a Schnitzler syndrome will happen in the adult. The earliest case has been described at the age of 26, but she's way younger than that. And we discussed the importance of the audiogram, and for a brain MRI may be too early in the process, but it is something that we should do, and probably a longer puncture will be useful too. So TRAPS, so this is the 5th historical autoinflammatory disease. I personally have not seen yet. I suspected a lot, but for now, it is not something that I have in my clinic. So TRAPS aim for TNF receptor associated periodic syndrome. T is for too long. The attacks last for a month and they can have a big period of latency. Usually those patients will have chronic inflammatory symptoms and it is a dominant disease. So the family history can be very present, but 50% of them are de novo mutation. And 20% of them will have symptoms only in the adulthood, but most of them before the age of 4. What they have as a characteristic is they have severe myalgia, and sometimes they are evaluated for dermatomyositis, but they have this rash that is localized, very painful, and if it is associated with leukocytosis, thrombosis, very inflammatory, of course. They also have other symptoms that we do see in other autoinflammatory diseases, but the main one is really the rash, the painful rash. The pathophysiology of TRAPS is not clear. We do know that it involves IL-1 beta, given the efficacy of this targeted treatment, and it is not part of the inflammasome. There is a signal that is not that is defective in the TNF receptor that leads to raw species production and leads to this TNF signaling pathway that is aberrant. But the clinical underlying pathophysiology is not really clear. In the real world, there is still a pretty good amount of patients that are on anti-TNF, like etanercept, but the guidelines really aim for an anti-IL-1 blockage treatment as the first treatment, followed by co-treatment with usually corticosteroids. So this is a little screenshots, usually. The table that resumes the 5 historical periodic fever syndrome that are resumed here. And I would like just to have a touch base on mosaicism. So we do talk about those mutations, and they are a mutation usually that comes as a germline mutation. But nowadays, more and more, we do see a lot of post-germline somatic mutation that too happens in the adulthood, and that do present exactly like our autoinflammatory patient, 60 years old with a CAPS, but with only 2 cells that are mutated that still cause the disease. And I think the disease that is the most popular now is the VIXAS syndrome. So that is linked to the UBA1 mutation mosaicism. And that's something you should have a look. And if it looks like really, if it looks like a dog, it walks like a dog, it is a dog. So if you think it is autoinflammation, even though your patient is not in the infancy story, you can still have a look for the genes. And depending on the type of the genes you have a testing, you can request different techniques. So there's a Sanger sequencing, and that is if you have a really strong suspicion, it is high, the likelihood is really high for this specific gene. I recommend more to do a Sanger sequencing. If you don't know, it is non-specific, the patient has non-specific symptoms, you may aim for a panel then with next gene sequencing panel. Maybe one day we'll have the whole exome, the whole genome, we don't know. But for now, that's really what we have here in Quebec. And do not hesitate really to call us if you have a doubt on, what panel, where to send it. Different panels exist and they are updated by different companies regularly. So I do recommend to have a look regularly. And some of the genes, are missing in some panels. So you can custom them or ask for another company to perform them. And we're all here to guide you if you need any opinion on what type of panel you want to assess. Of course, you're going to have the results of those panels. Sometimes it's clear, it's benign, there's nothing. Sometimes clear, it's pathologic, but most of the time it is not clear. It is the gray zone, and that's where I go with the InFever database that is very helpful for me to clarify the significance of a mutation. And sometimes we'll have to, do a trio with the family to assess the prediction of the prediction of the clinical significance of this mutation. And if available, functional studies was always helpful to assess, especially for MKD or other enzymes activity in usually research labs. This is a calendar that I like to give to my patient, all the time I say, okay, next time, document, I'll see you in 6 months, documents what is happening. And they are back 6 months after and they're like, oh, I don't know, I'm not sure, maybe 2 times, not sure. So I give them a calendar and it's a score called ADI Activity Score, has been published by Dr. Mariam Piram that is now at the Saint Justine Hospital. And it is a very good score with a good sensitivity and specificity. So I let them fulfill a daily calendar with their symptoms if they have a crisis. And next time I see them, they just bring it with them and the conversation is smoother and easier. I don't know if I have time for the last cases, but I just wanted to mention the Steel disease that this guy discovered a long time ago. And that is sometimes difficult to assess and to differentiate with HLH, for example, and that the cytokine panel can be very helpful, especially the IL-6 and IL-18, especially IL-18 levels, that in Steel disease is very, very high, up to 3,000 and plus. So that is something I use regularly to discriminate. And we do have at Sacré Coeur like a protocol for HLH. If you recall, the 23rd December at midnight, for a case, and in case you forgot to ask all the different stuff, that this protocol can be helpful. It is very exhaustive and has been put in place with different specialty, rheumatology, immunology, and hematology, and infectious disease. So it could be helpful too. And I'll be happy to share it. And of course, the anakinra is one of the treatments we use for that. So just to finalize, back then, autoimmunity and autoinflammation was really two separate worlds, right? Autoimmune is really the innate immune cells. You have antibodies, it's HLA related. It's completely different than autoinflammation, which is mainly the innate immunity, not the adaptive one. There's no antibodies and mediated by cytokine, not by the interferon signature. But it's not really true. Nowadays, we know it's completely a spectrum. Our primary immunodeficiency patients regularly go through that spectrums. And that's why we aim for a multidisciplinary clinic that we build up at Sacré Coeur Hospital with the internal medicine. So Dr. Stéphanie Ducharme-Bénard and myself and my colleague, Dr. Massé, we have once a week, a clinic that we assess our patient, because nowadays it's not anymore a spectrum and it's now not anymore clear cut, and our patients do share a lot of clinical presentation, and they do have comorbidities. So just for some examples, with the FMF, comorbidities can be associated with IBS, with psoriasis, with MS, and with also some cases of vasculitis, especially the IgA vasculitis that has 60 more times chance to have an FMF in his life. So just to think about it more frequently, and to refer it. I think if you think about it more frequently, you'll find more, definitely. Compliance is also something we have to review regularly. I do love the ADI score, and I recommend it to you. Targeted therapy and anti-inflammatory therapy do overlap, so we can play with it. And I think the field of genetic will reserve us a lot of surprises for the future. It is already done, but every year it's another add-on, another story. And maybe one day we'll have those genetic tests and those functional tests and cytokine, especially the AAS, done locally, maybe one day in Quebec. So thank you for your time.
Fantastic.
I'll take the questions.
Thank you so much for this really comprehensive review on such a fascinating topic. We do have a couple of minutes for question. Brian Gilfix, you have a question here. So, in spite of the actual simple
Yeah.
recommend genetic panel for periodic fever that includes MEFB, Hyperion fever is the most cost-effective approach and out-of-province test. Do you want to comment on that? Do you understand the question?
4 billion, like include. Okay, so yeah, of course, if you are sure of your shot, you can just assess an MUFV sequencing per se with a Sager if you don't think. But in Quebec, we do have a local 5 exons of the MUFV genes that can be done locally. I believe I'm not sure the site, but I think at Saint-Justine is done locally. So if you're sure that it is an MUFV or low likelihood is very high, this is way more enough. But if this is negative and you still aim for it and it still looks like it, I don't think the cost of the MUFV sequencing will be a burden, especially in this population. They do cost a lot because they do come to the emergency a lot, and they have perform a lot of tests, and so the genetic is sometimes useful, even though it is pricey for the patient perspective.
Yes.
Je vois pas les autres questions. Yeah.
Question, Hannah.
Yeah. Hi.
It has to do with SAA.
Yeah.
And in FMF,
Yeah.
in between the CRP normalizes, right?
Yeah.
What's the difference of the kinetics with SAA and CRP? What makes the SAA test more
valuable? Yeah. So depends on the patient. At the diagnosis, I perform both of them because some patient has a good correlation. So they have SAA, CRP correlation that are perfect. And for those ones, when I know it has good correlation, I don't usually repeat that. But some patients do not have correlation with CRP and SAA. And for those ones, unfortunately, we're not sure, if we should leave the SAA apart. For now, we do control the SAA for the one that has a discrepancy between CRP and SAA. But not all the FMF, for example, for the FMF, do have good correlation with CRP and SAA. Right. But it's probably just 30% of them.
There's a question for Robert Kiss. I don't know if you can read the question there.
Yeah.
If you can just answer.
So for the cases of MKD, MVK, the hypothesis was that production of prenyl group was impaired. Any evidence of decrease in production of or other intermediate of the cholesterol biosynthase pathway? Very precise question. No, I don't know the answer of that questions for Dr. Kiss. If there is any other cholesterol biosynthesis pathway that is aberrant, I'm not sure. I can have a look and maybe send you an email with the answers.
Okay, just a sort of from a big picture overview. We say that inflammation is a very important cause, long-term inflammation in, for instance, cardiovascular disease as well as many other diseases. Do you do, from my point of view, cardiovascular screening differently in this patient population, or should we be doing that?
Right. So yes, you're right. They may have in their life earlier cardiac issue, and that's something we do see, especially if the inflammation is not controlled. They also have, earlier osteoporosis because of the inflammation. So yes, there's the burden of inflammation goes in different area, but there's no clear now recommendation of prevention or dépistage for this population per se in the adult world. But clinically, yes, we do see it, especially for the one with uncontrolled long-term inflammation. Fortunately, those cases are less frequent now that we have more awareness and that the colchicine exists also. But yeah, that's a very good question, especially for the one that has chronic inflammation.
Okay, so to be followed. Okay, so are there any other questions? Otherwise, we're coming up on the hour. So
there's one.
Oh, there's a question that Kaberi, just quick question.
Because I'm thinking as a general internist, entering these pathways which are complex. So besides the fever, I saw a few times secondary amyloidosis.
Yeah.
With the serum amyloid level be useful to kind of guide us in this direction, or how, is that some kind of decision node point so we know to start looking for preferring?
So I may repeat the question just for the audience. So the question, if I have well understood, is the secondary amyloidosis in those patients and the guidelines with AAS dosage level. Is that correct?
It's more to say, could that be used as a way of sending us on a pathway, like, is that common enough across those conditions?
So AAS can be, serum amyloid A can be elevated in a ton of different situations. Unfortunately, it is non-specific. We do use it in our autoinflammatory disease because there's literature saying that the higher the AAS is, there's more risk to develop amyloidosis in the future. So that's why we treat to target with this level in mind. But they have a fever, they have a flu, it's going to be high. If you're facing a lymphoma, it's going to be high. So no, for now, it's not helping to really understand amyloidosis pathway necessarily. Yeah.
Okay. So thank you so much. A really fascinating topic. Congratulations on setting up your program and that multidisciplinary clinic. It's a great initiative. Thanks everyone for participating, and I wish everyone a great afternoon. Bye-bye.